Good evening, everyone. My name is Errol Moras. I'll be presenting today's afternoon report. Today, we have a young female, 54-year-old, presenting with a past medical history of lymphoma. She comes to the emergency department, referred from her outpatient clinic with three chief complaints, mainly fever, tachycardia, and hypertension. So just to go into the history of presenting illness, she's 54, past medical history of an anaplastic large cell lymphoma.
Errol, we still see the first slide. Can you go to the next slide?
I moved it.
Or we just share it from here. We have it here. Yeah.
Okay,
now we can.
Okay, this is fine.
Yeah.
All right. So we have a 54-year-old female with a past medical history of anaplastic large cell lymphoma. Initially, she went to her outpatient oncologist on the 2nd of November for her new cycle of chemotherapy. Basically, she's been through a lot of chemotherapy cycles, but this was just a new cycle that they wanted to try. And it's called the BV cycle with brentuximab and vedotin. So she came to the clinic. She was febrile to like 102, hypotensive, as well as tachycardic initially when she presented to the clinic. When she came there, they gave her a liter of IV fluids, sent for like basic labs, cultures, gave her 1 dose of an IV antibiotic, and sent her immediately to the ED for admission. When she came to the ED to see us, when I saw her there, she was febrile, tachycardic. When asking her, she said she endorsed feeling fatigued for the last few days, along with chills and rigors for the last 3 days. In addition to that, she had 2 episodes of diarrhea as well, but she was rather attributing the diarrhea to a new antibiotic, which she started for her CMV prophylaxis. Otherwise, she complains of no abdominal pain, no distension, no constipation, denies symptoms of chest pain, shortness of breath, no rash, no new swelling. She had a PICC line on the left side, but there was no pain, no induration at the side. And she lives just with her husband and her kids, no sick contact, hasn't traveled anywhere, and she's vaccinated for COVID. So to go next into the past medical history. So she's a cancer patient, so she has like a very large medical history. So she was diagnosed with her anaplastic lymphoma back in November of 2020. And then she went 2 cycles of this BV chip chemotherapy, following which her flow was found to be positive. And then after that, she was started on 2 more cycles of BV chip, E is the etoposide. So she failed that as well, following which they started anthracycline for 6 cycles, along with IT methotrexate, as well as an immune therapy. Following that, they did CT scans to see that there was minimal residual disease. So they decided to go ahead with a bone stem cell transplant. Following the stem cell transplant, she was doing quite really well, but 4 months after that, her course was complicated by a CMV viremia, following which she was put on prophylaxis with letermovir. She went on like this, despite the bone marrow transplant. When they checked her scan 6 months later, they showed that there was residual disease as well. So after that, they enrolled her in a new clinical trial with a new drug, as well as CMV prophylaxis, but she continued to progress on the disease even in October, and she was taken off the trial chemotherapy due to progression of the disease. So the new plan for her was to start her back on the BV chemotherapy due to failure of multiple chemo regimens, and that's why she went to her outpatient oncologist towards the end of October. So to go into her current medications, she's on vitamin D, she's on CMV prophylaxis for letermovir, she's on acyclovir prophylaxis, some vitamins, folic acid, and some eye drops, as well as pentamidine. Nothing too great otherwise. So in terms of her family and social history, no history of alcohol, smoking, or any drugs. She hails from Guyana. She has 3 brothers and a sister. All of them are well, no family history of cancers. She lives in New Jersey with her husband and 2 children. And they don't really often have like visitors just because she's undergoing a lot of chemotherapy, stem cell transplant. So they take measures just to keep her safe. But otherwise, her history was notable for she was working as a pharmacy tech in preparing chemo drugs for the last 15 years. So she probably attributes this to like some form of exposure during this, but we couldn't really attribute anything to that. In terms of allergies, she has none. In terms of review of systems, she was positive for chills, fever, and some fatigue, and diarrhea. Just 2 episodes of diarrhea, one just 2 days before presentation, and other one was 6 days before presentation. Otherwise, her review of system was unremarkable in all other systems. So
let's just go back to the first HPI slide.
Sure.
All right.
Yeah.
So now, what more questions do you have for, what would you want to know when you see this patient, either in the ED or in clinic? Anything else you want to elicit? This patient, or do you think you have enough history to move on to your investigations? Okay, Victor asks, any respiratory symptoms?
No respiratory symptoms on presentation.
Previous sick contacts or TB exposure?
No. She stays pretty much safe at her home, just in one room with her husband, but nobody else.
I just want to put for what's your approach when you're seeing this patient? This is a patient who is a cancer patient on some getting some kind of anti-neoplastic therapy, and now comes in with fever. So how important, or what are the important questions you need to ask? Daily, any recent hospitalizations?
So she's been on chemotherapies for a long time. So she's been in the hospital on and off since being diagnosed with chemotherapy since November of 2020. So just for chemotherapy cycles, she's been hospitalized and discharged, but nothing acute otherwise.
Joe asks, any recent antibiotic use?
Not that I know of, not on presentation.
Low urinary tract symptoms or abdominal pain?
No, nothing.
Asks, history of febrile neutropenia.
She never had previously any documented history as per her chart, but this was her first presentation with fevers.
Okay, so that's a great point. So history of febrile neutropenia. So whenever you have a patient who's on anti-neoplastic therapy, that's one of those clinical emergencies, not emergency, but those clinical scenarios where you have to have a high index of suspicion. And as we think of patients with STEMIs and patients with critical limb ischemia, febrile neutropenia is one of those conditions which interventions in the first 60 minutes will have an impact on this patient's mortality. So that's something you have to be very, very cognizant about when evaluating these patients with previous cancer. On the same lines, febrile neutropenia is, it's a diffuse entity. So you also, or like a large, broad entity, you want to characterize what the specific clinical syndrome is. So you have to elicit a history, you try to elicit a history of some kind of, specific infectious clinical syndrome, like a pneumonia, a cellulitis, mucositis, or any other syndrome which is a definitive clinical infectious syndrome, so that you know what kind of therapy you will offer this patient and what kind of investigations you will do. Because you can do large batteries of tests and do every test known to ID, but at the end of the day, a good history and physical will be the best at determining what kind of what kind of focus test you can do and what therapy this patient should receive. So that's very important to know. Okay, we've ruled out a GI source, or we've ruled out a lower urinary tract infection, pneumonia. This patient has a PICC line, so you also want to make sure they don't have any signs of a central access related infection. So that's something you want to approach this patient with. You want to, number one, find out how high the risk is of this patient having febrile neutropenia based on what kind of chemotherapy this patient was getting. Number two, how what kind of syndrome this patient may have, cellulitis, pneumonia. Based on that, deciding what kind of tests you need. To the examination, because that will also allow us to try to get a framework of what kind of clinical syndrome this patient might have.
All right. In terms of her vitals, her BMI was 19. Her blood pressure was 100/66. This was after she got 1 liter of IV fluid in the ED. Her heart rate was still tachycardic. She had a temp of 100.8. after she got 1 dose of Tylenol, and her respiratory rate was 18 in 96 on room air. In terms of physical exam, she's a young middle-aged female, didn't really appear in acute distress on seeing her. In terms of positive findings, she was tachycardic, her heart symptoms otherwise normal heart sounds, no murmurs. In terms of respiratory, clear to auscultate bilaterally, no wheezes, rhonchi. Her GI was no organomegaly, non-tender, non-distended. There was no Foley. In terms of her skin, there were no rashes, normal turgor. In terms of neurological exam, ANO ×3, no focal deficits, and her PIC line on the left side was intact, non-indurated, non-tender.
Examination you want to pay close attention to? Any pertinent negatives here which are important in this patient? Which sticks out, or what? Okay, normal abdominal exam, that's something. Abdominal tenderness, clear lungs. Okay, so these are things which you might say might not be a GI source, might not be a respiratory source, but what's your, in a patient with a PIC line, what's very important? You want to make sure the patient doesn't have a catheter-associated bloodstream infection, right? That's more common. That's very commonly seen. So your physical exam of the PIC side is important in this case. So that's one thing to note. The other two things are, number one, no rash. Rash is also extremely important because cellulitis might be an important. It might not just be the the primary syndrome, but it is also like an area where bacteria can to come into the body. So that's important. And lastly, mucositis. Patients receiving chemotherapy, oral mucositis is an extremely common cause of febrile neutropenia. It can be the source of infection for these patients. So apart from your general respiratory examination, abdominal examination, some things you have to pay attention specifically to these patients is mucositis, rashes, and the central access or any kind of peripheral access. Even if they had a peripheral line, if there's any signs of thrombophlebitis there, that could be your potential source. So you have to make sure that you notice these in these patients. Go on to the next slide.
All right. So we have the first set of slides. These were the admission labs. She came in with a hemoglobin like 5.5, platelets of 25. Her ANC on presentation was normal. Her WBC was 3.4. This was day 2. She got 2 units of blood, following which it was 9.5. She got 2 units of platelets as well, but in spite of that, it was still like 17. And these were her labs after that. All right. And so just want to see problem representation if anybody wants to try.
Go back to the first HPI slide. So we have problem representation. We always talk about who is our patient. Group. Who's gonna help us? Take a stab at it before I volunteer you.
Volunteer the.
Okay, so let's see. Alex.
Axel, you mean?
Sure, if you're there, but I mean I was volunteering our intern Alex. You help. All right, Axel.
Sorry?
Let's keep it simple. So who is our patient? What's the age group? Is this a young patient, middle-aged? Dr. Errol is listening.
So this is a middle-aged female, 54 years old.
Pertinent past medical history you need to keep in mind when evaluating this patient?
Yeah, anaplastic large cell lymphoma is the main part of the past medical history. Extensive chemotherapy, now on brentuximab vedotin.
So middle-aged female with a past history of a lymphoma on chemotherapy. So that gives us an idea of whom we're talking about. Now let's talk about, we know who the patient is. Now what is the patient coming with? What clinical syndrome?
She's coming in with neutropenic fever.
Yeah, neutropenic fever because we know the labs, but even before the labs, you can see the patient's blood pressure here, hypertensive to 88/55, tachycardic and febrile. Is there anything else you would like to frame this as in the ED before you even have this patient's labs?
Was a neutropenic sepsis.
So yeah, this patient's presenting with sepsis. And once we know the labs, we can say, okay, this is neutropenic fever with sepsis. And any focus of infection, is there anything in the exam or in the history which makes you think we might have, or which might help you localize the source of this patient's neutropenic fever and sepsis?
No, that doesn't seem to be very well localized at this stage. So treating broadly would be the first imperative.
I would agree. I think this patient had, patient had diarrhea, but I don't think it's slam dunk in this case because the patient didn't have abdominal tenderness and diarrhea can be non-specific. So even though the patient does have some clinical history, I wouldn't bet my money on, okay, this being a GI source of neutropenia. Female who presents with previous history of lymphoma on chemotherapy, who presents with sepsis and possibly seen to have neutropenia, so neutropenic fever. Let's just show your problem representation and then we can go ahead into our discussion.
All right, so this is a young middle-aged female with a history of anaplastic large cell lymphoma, multiple chemotherapy treatments with residual disease, failed a bone marrow transplant complicated by some viremia with relapsed disease, now presenting with fevers, tachycardia, hypotension with labs notable for pancytopenia.
Great. Yeah, so being more specific, it's not just neutropenia, it's pancytopenia. Before we move on to our discussion, Victor's asking where is the bulk of her disease in her lymphoma? Like where does her lymphoma present?
So initially she had a pelvic lymph node on presentation, but this time when she presented mainly on her PET scan, it was more like diffused, some in the thyroid, some in the pelvic region, some as well as in her abdominal region.
So sort of generalized.
Yes. Yeah.
Okay, let me share my screen and then we can talk about neutropenic fever.
Okay.
We know this patient has febrile neutropenia. To take a stab at how we define febrile neutropenia. There's two aspects to this, right? Fever and neutropenia. How would you define the fever? This definition, go ahead.
So I was going to say temperature above 100.4 and then neutropenia, an ANC, I think it's 1.5 or less.
So yeah, both, this was sort of a rhetorical question, but not really. So fever has had different definitions, based on whom you ask. But we'll go by whatever the IDSA has said in their latest in the guidelines for febrile neutropenia. And they sort of have a definition which is a little more confusing. Say if it's a single oral temperature of greater than 101, that is a fever, or a temperature of greater than 100.4 for sustained over a 1 hour period. We all know that patients who have fevers, we're not going to be waiting for an hour before we give them Tylenol. So for practical purposes, we're always going to be using 4. But just so that fever can mean different things, and also is depends on what the patient's medications are. So if the patient's on steroids, the patient's on Tylenol, 100.4 is not going to be a fever for them. You have to have a lower threshold for those patients. So in those patients, you have to look at the patient as a whole, and you have to think about other signs you'll see in an infection, like tachypnea, tachycardia, hypotension. In an afebrile patient who is on steroids or who is on Tylenol, these are other markers that this patient might have an infection, and a fever should not be the only marker of an infection. And neutropenia, as Tom rightly said, most guidelines say 1.5. That's 1500 per cells per microliter, and that's 1.5. And there's also severity of neutropenia. So most guidelines also say classify severe neutropenia to be less than 500 and profound neutropenia to be less than 100. To take a stab at why this is important. Why is it important to differentiate levels? Yeah. Why do you think it would be important? It's sort of common.
I don't have the bugs, but this stratifies a person. If they're less than 100, you're really treating them very differently than if you're less than 500.
That's basically it. You want to risk stratify your patients because not all of these patients are the same. Some might be much more stable than others, and based on the severity of neutropenia, your coverage might, you have to think about other bugs rather than just bacteria. So we can talk a little bit more about that later, but moving on to how you calculate the absolute neutrophil count. Obviously, in most situations, you'll just see it on Epic in the labs. But what if you don't have an absolute neutrophil count? Do you know any way you can calculate it just based on your differential? Differential which can help you calculate the absolute neutrophil count?
Don't you have like your total white blood cell count and they give you a percent neutrophils in your diff? You can multiply?
Yeah, you'll get a percentage of neutrophils, EMNs. And so what are bands? Bands are immature neutrophils. Precursor of these are immature neutrophils, and when we talk about left shifts, basically that's these bands, and they might sometimes not be included in your percentage of neutrophils. So when you have a high proportion of bands, it's important to add these to your percentage of WBCs. And this is a percentage, sometimes this is an absolute number. So when this is a percentage, you again multiply it by the WBC count and then add it. And if it's an absolute number, I'll add it later. Right. So we now have our absolute neutrophil count. We know patients' ANC is. Medicine like to classify everything, right? It makes for good exam questions. So is there any classification of fever anybody wants to take a stab at or has heard about? There's 3. First one is some neutropenic fever syndrome which has microbiological documentation. Neutropenic fever syndrome, which, after the patient's been in the hospital, the patient's been identified the focus of infection, whether this was a skin and soft tissue infection, whether this was pneumonia, where the body was infected. Plus, because of the cultures you sent, you also know what bug was causing it. So you know both. You know the focus of infection and you know the pathogen. Sometimes you will also have some patients where you'll have a clinically documented infection. You know this patient has a pneumonia. You saw it on the X-ray. You know this patient has a cellulitis. You saw the rash. You know the patient has mucositis. You have evidence of mucositis. The culture which was positive. Clinical focus, but you don't have a pathogen because the cultures were negative or the cultures were not sent. And the last is unexplained, where you don't have, a patient came in with a fever, but you didn't have any physical exam findings or it didn't have any focus in on one organ system which was infected. And also all of the cultures you sent, all of the tests you sent were negative. So you don't really know what was causing it. A lot of times these will be your patients. They will come in with fevers. They'll have no other, specific signs or symptoms, and you don't know how to treat them and how long to treat them for. So for that, we rely on, previous data to see what was the best treatment for these patients and treat them accordingly. Because if you know what organ system was infected, you can treat accordingly. You can treat the pneumonia for 7 days. If it was a bacteremia, gram-negative, we know we treat those for 14 days. But for unexplained infections, you need to go as per, what regimens will lead to decreased mortality, and that's how you decide how long the patient gets treated for. It's also important to know which patients have persistent or for persistent neutropenic fever or persistent neutropenia. It's 5 days. So if the patient's been in the hospital or been on outpatient therapy for greater than 5 days on empiric broad antibiotic therapy, West, the Tylenol and be afebrile for the next 6 hours, but whenever the next dose of Tylenol is due, whenever the Tylenol is out of the system, the patient spikes a fever again. And this has happened despite 5 days of empiric broad spectrum therapy, these patients are said to have persistent neutropenic fever. And that's important because, in those patients, you have to think about changing your regimen, testing for other causes of neutropenic fever. So now let's talk about something we alluded to earlier, risk stratification and risk assessment. Does every neutropenic fever patient need to be admitted to the hospital? This patient came in with, sepsis and was hypotensive. What if the patient did not come in with hypotensive and the patient looked well? Would you admit every patient, or has anybody seen any patient who has not been admitted to the hospital? I think our experience is biased because we only see the patients who are admitted. But if you were shadowing an oncologist in an outpatient setting, you would see a lot of these patients who didn't, they look good. They had a fever, but they did not have systemic signs of infection. They were not hypotensive. They were not hypoxic. So they did not have any reason for admission. But, we don't want to rely just on the patient, on the physician's gestalt, and we want to have objective parameters to decide whether this patient needs to be admitted or not. And so for that, we have risk stratification scores. Another thing we like, scores. So one score we use commonly is the MASC score, MASCC. I think I can just go through the score ourselves. Febrile neutropenia. So this is a very well validated score and helps you decide whether this patient needs to be admitted or not. So this is sort of subjective, burden of illness, symptom severity as determined by the attending physician at presentation. But apart from that, most of these things are pretty objective. And the things they include are hypotension. Of course, we want to make sure the patients are not in shock, COPD, because that's an important comorbidity, type of cancer, because hemolymph have a higher risk of severe neutropenia and poorer outcomes as compared to solid tumors. And then hydration, whether the patient's already as an inpatient or is an outpatient, and age. So rather than going into all of this right now, I'll just tell you the short and sweet summary. The patient has a MASCC score of greater than equal to 21. The patient is low risk. And this is, a high score means a patient is less sick. So if it is a score of 21 or greater, that's a low risk patient. And these patients, if they don't have any other indication for admission to the hospital, they don't have hypoxia, they can tolerate oral therapy, they have good outpatient follow-up, these patients don't even have to be admitted to the hospital. Of course, if this patient has any other reason for admission, this patient has, severe nausea, vomiting after chemotherapy and can't keep their medicines down, you will admit them to the hospital. Or if this patient can't walk because of some other reason, you would keep them in the hospital. But selected patients in this low risk category can be treated as outpatients. Score is less than 21. These are sick patients and these are high risk patients. These patients to the hospital for IV therapy. There's some other scores, but the most common score is the MASCC score, and which is a question in the boards as well. So these two are just for, just to round out the list, but the MASC score is something you will be using. Let's talk about how to measure the temperature in these patients. What are the things you can use, or what are the methods to measure temperature in a patient with a fever? Victor, I just saw your comment. Great, you got the MASC score. Yeah, so Victor and Emily, correct. No rectal temperature. You don't want to seed or give the patient have any rectal manipulation, because that can seed these patients. The flora can be seeded into the blood. So no rectal temperatures. You would use oral temperatures in most patients, unless the patient has severe oral mucositis, and it's because if the patient has mucositis, it's going to be inflamed and it's going to be warmer than their actual temperature. So in those patients, you can use axillary temperature, but in the vast majority of patients, we would use an oral temperature. About the pathogenesis, what's the most common source of infection in these patients, or what's the most common way these patients get infected? IgU. Okay, so amongst these, Victor, would you think GI is more common or GU is more common? Correct. So the most common way these patients get an infection is seeding to the bloodstream from the flora in the gut. So bacterial translocation. Yeah, Joe's got the right terminology. Seeding from bacterial translocation into the gut. Which bugs are most common? Has anybody treated a patient with what bugs do you cover? That was a trick question. You cover for gram negatives, but the most common cause is actually gram positive bugs. Bugs used to be the most common cause prior to the 1980s. Now, over the last few years, the gram-positive organisms are more commonly, like they're about 60% the reason for these infections. And that's been well validated in studies which were used to validate this or used to calculate the MASC score. And amongst the gram-positives as well, staph epidermidis is the most common cause. Why, even though gram-positives are more common, why we actually treat for gram-negatives rather than gram-positives. Before we move on to actual treatment, what other causes of infection can lead to fever? Okay, we talked about bacteria. They could be gram-positive, gram-negative. What are other causes of neutropenic fever? Viral. Organisms. Can you tell me what are the most common? And which fungi cause neutropenic fever? Great. Yeah. Go hand in hand in neutropenic fever. Great. Who are the most common cause of fungal neutropenic fever? We said persistent and recurrent neutropenic fever are important to be noted because These are more commonly seen in patients with persistent neutropenic fever. And if a patient was coming in with, first episode of neutropenic fever and is in the first day of treatment, you won't think of these unless the patient has some other risk factor for a fungal infection. Suppose the patient has had a previous fungal infection, or the patient had a stem cell transplant and is, and is neutropenic because of that. Those are patients you have to worry about fungal infection. But in the other vast majority of patients, you would think about fungal infections later on in their course if they've been febrile despite 5 days of antibiotics. Viral, what viruses do we know which can cause neutropenic fever? EBV, these are less common. They are on the list. But the most common ones would be HSV. Exactly. So HSV 1 and 2 reactivation is actually the most common viral cause of neutropenic fever. It's not a primary infection. It's HSV 1 and 2 reactivation in patients who were previously infected and now are neutropenic. Can manifest as their recurrent HSV 1 and 2. From that, in this era, you also have to think about COVID. COVID patients have more severe outcomes or worse outcomes, and as well as flu. How soon should these patients get antibiotics, and how would you time this with cultures? Duration. Take home message for me from today is to needle or door to balloon time. Neutropenia has a time to antibiotic therapy, which is less than 60 minutes. Presentation. It is actually well studied that a patient does not get antibiotics within neutropenic fever patient does not get antibiotics within 60 minutes of presentation to the emergency room. These patients have a higher mortality. Well documented. So giving these patients antibiotics is extremely important, and sometimes takes precedence over ordering a chest X-ray or getting you want to do in these patients to make sure you have something to treat is you get blood cultures and 2 sets. As soon as you have blood cultures, you give these patients antibiotics, and you would not even wait for a chest X-ray. You would not wait for any other labs apart from a CBC, of course, because you don't know they're neutropenic unless you. So logistic question about blood cultures. Suppose in this patient you want to get blood cultures. How many would you get, and where would you get them from? Talked about something this patient has. So this patient has a PICC line, so you want to make sure you get one from each lumen. If this patient had a triple lumen central line, you would want one from each lumen, and then you would also want 2 sets from the periphery. Do you know why is this important? What do you gain from this, or what's the importance of having a culture from the line? I drew to know if it's from the PICC. Yeah, so that is why. But how do you find out something is from the central line or if it's from the blood? Because if it's from the blood and not from the central line, it's still going to be positive in the PICC line. The PICC is positive and the rest are negative, could be PICC. That is true, but what I'm looking for is exactly who answers, who grows fastest. So if the blood cultures from the PICC grow at least or at least 2 hours before the rest of the blood cultures, that's called the differential positivity rate. And if it's more than 2 hours, that means the likelihood of the patient having a central line infection is high. So, all right, we don't have to forward. We'll quickly talk about antibiotic therapy, and most of us know about it. So, what antibiotics would these patients with neutropenic fever receive? What do you want to cover? Fluoroquinolones. What things in this patient? This patient's sick in the hospital. What would you give? And what are you covering? To cover these patients for anti-pseudomonal. So the treatment of neutropenic fever in an undifferentiated patient is anti-pseudomonal therapy. That's the very least. Who would get VANC? Does every patient need VANC? What are the indications for VANC? That's correct. Broad spectrum therapy, VANC and cefepime. Let's just quickly go through them. Yeah, lines, a pneumonia, cellulitis, skin and soft tissue infection. So these are patients for gram-positive culture, gram-positive coverage, and obviously, if you have a positive culture, you would treat accordingly. Treat these patients with antibiotics for. We talked about it a little bit in the starting, but based on the clinical syndrome. So if this patient has a pneumonia, treat them for 7 days. If this patient has, cellulitis, you would treat them accordingly, 5 to 7 days. If the patient has bacteremia, those are treated for 14 days. Depends on what the patient actually has. But if you don't know what the patient has, then you treat them till they're neutropenic. So you cover them till their ANC doesn't go greater than 500 and they're afebrile for more than 2 days. Who've been on antibiotic therapy for 4 to 7 days and still febrile, and you have no other source. Those patients would be empirically covered with cascofungin or amphotericin based on what your comorbidities are and what fungal agent you're suspecting. Okay, so that's enough about neutropenic fever. Errol, you want to start talking about this patient?
All right. So just a brief overview of how to approach febrile neutropenia in a cancer patient. So pretty much the same, just like Angad said, this patient came in with fever, tachycardia, and hypotension. So the initial thing is just put an IV access, get all the cultures done, get routine blood work done, and then assess the patient, triage it quickly if the patient is severely septic or if the patient just has a sepsis syndrome, and if the patient is at high risk or low risk. So what do you mean by high risk or low risk is usually, high risk is usually with a mass score of less than 21, as we spoke. And then you have a CISNI score of greater than 3, as well as if you have active uncontrolled comorbid medical problems like severe sepsis, GI mucositis, IV catheter infections, anything on chest X-ray, or if you have like COPD, asthma, or a complex infection at the time of presentation. As well as a couple of these patients also fail like multiple lines of chemotherapy. So they're also at very high risk of progressing. And the other thing is those who have hepatic insufficiency as well. So this is just an algorithm how to treat neutropenic fever despite empiric antibiotic therapy for those who progress with fevers for 2 to 4 days. So low risk patients, usually those who have unexplained fever, and if they still have persistent fever and they're unstable, just hospitalize them for IV antibiotics. If the fever has subsided, you can continue the oral or the IV antibiotics and switch the IV from IV to oral. For high-risk patients, like we spoke about, if they have persistent fever and don't change the empiric antibiotics, just look for other infection site, look, scan, like do a chest x-ray, pan imaging, do another set of blood cultures, just look for new sources of infection. Because in these patients with neutropenia, infection is the #1 cause which, for fevers, and you have to rule out infection at least till you don't find a source. So for our patient, her other labs, in terms of she was hypokalemic when she presented. Her magnesium and phos were a little low, but that's not very significant. But in terms of other labs, her ferritin was remarkably high in terms of 16,000. Her LDH was elevated. Her haptoglobin was low, and her soluble IL-2, which is quite specific for a syndrome, was greater than 20,000. Her triglycerides were elevated. And so basically her infectious workup, her urine analysis was negative, her SP panel, COVID, blood cultures, forceps, everything was negative. Her CMV was positive, but this was the previous CMV, which was detected maybe 4 months back, but her titers were decreased since then. So not really significant for us this time. We did an EKG, which was just sinus tachycardia. Her echo was pretty normal, even though she was on multiple chemotherapies with an EF of 57%. We did imaging of chest x-ray, did a CT sinus, which was negative. Chest CT abdomen pelvis showed like bilateral ground glass opacities, but this was probably initially thought to be like infectious or inflammatory. So pulmonary was consulted. They thought that this was just a progression of the disease rather than a new infection. So we did a MRI brain to see if there was any other source there. MRI total spine with contrast, couldn't find a source either. So finally, she was still progressing with fevers almost every day for like 5 days. And so we decided to do a bone marrow biopsy. And on the bone marrow biopsy, her flow was found to be positive, and the pathology was positive for a syndrome known as HLH, so which showed like evidence of hemophagocytosis. And that's why that pretty much explains like why she had these fevers despite like every infectious workup being negative. So just to sum up what happened to our patient since being admitted, she continued to be febrile for like 5 days, but otherwise her other vitals were stable. Her pan imaging was unrevealing except for the CT chest abdomen pelvis, which had those ground glass opacities. So we just put her on empiric antibiotics. She was on IV wank and Zosyn as well. Her infectious workup was everything was negative. She was treated with IV antibiotics as well as high-dose steroids. So high-dose steroids is usually started in patients who you suspect HLH, but we didn't have a confirmatory source initially. So this was started on day 4. Her labs continued to worsen despite transfusions. She had pancytopenia almost every day, despite getting daily blood transfusions for RBC as well as platelets. Her ferritin continued to rise, as well as the soluble IL-2 was really high. Bone marrow biopsy, as you saw, was positive for HLH. And eventually, like on day 10, her course was complicated by hypoxic respiratory failure, following which she was taken to the ICU and intubated. So in the ICU on day 12, she continued to deteriorate with refractory hypertension, dilated ventricles. She also had these labs, which were significant for spontaneous tumor lysis. She was treated in the ICU, but eventually her husband decided to like change the patient to like, her core status was changed to DNR. So this patient basically came in with like fever, hypotension, and tachycardia, progressed pretty quickly over the span of like 10 to 14 days with like multi-system organ failure. And this was most secondary attributed to HLH. So in the end, the decision was made to discontinue all therapies, and she passed away on the 16th day after her admission. So just to sum up what HLH is, in addition to febrile neutropenia. So HLH is a syndrome which is quite rare, but life-threatening. So it's important for us to like be aware of this. So it's basically an immune activation of lymphocytes and macrophages, and where you have this unregulated cytokine production, which which causes a multi-system organ dysfunction, rapidly leading to death. And so HLH can be classified as primary and secondary. Primary is most common seen in infants and very early childhood. The secondary is the most common one, which is more common in adults, secondary to infections. So that's why you always have to rule out infections before thinking of any other causes. The second could be due to malignant diseases, lymphoma, like as you see in our patient. Also, patients who are on stem cell transplants, those who have immunosuppressive therapies, they can be susceptible to this. So how do you diagnose HLH? So you have a few criteria. So most common thing you see in HLH is fevers, which are persisting despite Tylenol as well as IV antibiotics. Organomegaly is quite common, but this was not seen in our patient. A couple of patients present with seizures, ataxia, and altered mental status as well. Rash is also a very important clinical finding, which you see in most patients, and lymphadenopathy. This is most commonly because of the disease. In terms of diagnostic criteria, you can go ahead and diagnose either way. There's either a molecular diagnosis or there's a clinical criteria based on which you can diagnose a patient with HLH. So the molecular diagnosis, you have a couple of genes which you have to test in the laboratory, and positivity confirms HLH. But the most common in the hospital which we use is the clinical criteria. So usually you need 5 out of the 8 criteria which are present here. So fever greater than 38.5, organomegaly, cytopenias in at least 2 cell lines. So we had anemia in our patient as well as thrombocytopenia, as well as ANC, but this was not on admission. This was eventually on day 5 or day 7. Hypertriglyceridemia, hypofibrinogenemia, hemophagocytosis seen in the bone marrow, low or absent NK cell activity, rising ferritin, as well as a positive soluble IL-2 as well. So in terms of treatment, how do you treat these patients? So you treat them either with high-dose steroids. You can go ahead, if there's CNS disease, you can go ahead with IT methotrexate along with steroids. Etoposide is quite promising in quite a few number of patients, but right now, a lot of patients have been trying on IL-1 antagonists, as well as this interferon gamma, which is quite commonly used at Sloan. For long-term treatment, stem cell transplant is the best therapy. But most patients fail. So you always have to put these patients on supportive treatment like PJP prophylaxis with Bactrim, PPI prophylaxis, PPIs for GI prophylaxis, antifungal prophylaxis, as well as ESBL coverage as well. So just take home points about febrile neutropenia and HLH. So febrile neutropenia requires prompt evaluation and initiation of broad spectrum antibiotics. People with heme malignancies are the most highest risk of suffering from them. And among them are the people who have induction chemotherapy, as well as those undergoing stem cell transplant. And among stem cell transplant, allogenic transplant is very high risk for progression. For a patient with neutropenic fever, remember that the body's own flora is the greatest danger. So always try to isolate, but do not wait to initiate treatment. HLH as well is a very underdiagnosed condition, but it's a life-threatening syndrome. So it's always nice to keep it in the back of our mind. The response is best seen when you start the therapy as soon as possible, which will help to ease out the condition. But for patients with refractory disease, stem cell therapy is the best mode of transplant, best mode of therapy. And patients who fail that, usually there's not much you can do for them. So that's pretty much it.